Hello and welcome to the podcast Eat Better Food Today. I'm your host, Ken Coonahan, and I'm excited to be sharing insights on why we believe that health and longevity begins with the food we eat. The goal of this podcast will be to inspire, educate, and enable folks to live a healthier life and do it affordably. My wife and I have been on this journey for over 10 years and continue to work on it every single day. Percent of the profits from this podcast will be put towards child hunger with an initial focus on the poor suburban America, East Cleveland, Ohio. As a reminder, please subscribe to this podcast. Subscriptions are the lifeblood of any podcast. On this episode, we're grateful to have Dr. Gary Schwartz. Dr. Schwartz is the director of the Case Comprehensive Cancer Center in Cleveland, Ohio here, formerly the chief of Hematology and Oncology at Columbia University Irving Medical Center and deputy director of the Herbert Irving Comprehensive Cancer Center. And his vision is to establish a highly innovative, transformative, clinical translational research program in the field of cancer therapy. Dr. Schwartz and I met at a community event hosted by Case at the Cafe Loiter in East Cleveland several weeks ago. In this episode, we'll explore Dr. Schwartz's thoughts on food, health, and longevity and discuss what continues to inspire him. So welcome, Dr. Schwartz.
Thank you, Ken. I appreciate the invitation.
So my first question is always about food, something I believe is a good start to the day. So just curious what you had for breakfast this morning.
This breakfast, I had a bowl of fruit, cereal, and fat-free milk.
Nice.
Yeah,
nice.
And I start with that every day in the morning. Usually grain cereal with blueberries and raspberries, and I usually have a little banana on top of that, and no fat milk. And I start my day every day with that breakfast, pretty much. That and exercise.
That and
so
exercise.
I start the morning with a 3-mile jog, usually on the treadmill.
Okay.
Of course, I put on my favorite Netflix show, and it goes very quickly. And just to get exercise in every day with good health and eating the right foods is a very positive approach to cancer prevention. And I recommend it strongly. And not just cancer, but even managing all the other issues we face from hypertension and high cholesterol and cardiovascular disease. I think good health, which comes from exercise and diet and proper food, all contribute to overall improvement in health, increased longevity, and of course, cancer prevention, which is what one of my big focuses.
Well, you're putting me to shame here. I ran a mile this morning. So.
Well, let's start. Listen, I think you don't have to do 3 or 1. I think any time you increase your heart rate and break a sweat, then you're contributing to your overall well-being. You don't have to do 3 miles. That's what I aim for. And frankly, I get up on that treadmill some mornings and go, how am I ever going to do this? Like this morning, and I getting out of bed was like, oh my God, I've got to get up on that treadmill. But I do it every day. And you know what? I feel so much better.
I feel so much better when I do it too. I have the same, trying to get up, do it early, and kind of before the day starts. Yeah.
Well, my motivation is our black lab. So we have a black lab. And, at 6 a.m. in the morning, she's on my bedside with her head's by my bed. And she's looking at my face, it's time to go. So I'm the first one out of bed, my wife sleeps in, I take the dog out for the walk, and then I'm that early, it's too early to go to work, so I don't want to go back to bed, so what better time to exercise than first thing in the morning, and that's my routine. And I take a Monday off because I have other things going on, but I try to really make that routine. I think that's something, once you have a routine, it's easier to do. And I try to doing exercise after work some days, sometimes I do, sometimes I don't, I'm too tired. But I make that a routine, that plus a healthy breakfast.
Nice.
Now, will it make me live longer? I don't know, but I feel good about it.
I think it will.
Yeah.
I mean, I feel good about it too. I mean, it's tough to get out of bed, but the end result, I always feel good after a run, so.
I think my heart rate's better, my blood pressure was always borderline has improved, I can think I feel better, and I just there's a physiological improvement, whether it's endorphin release from the exercise, there's something you feel good about that. And then you have a goal. You achieve something. And that's something positive for people in general, to have a set goal that you can achieve and say you did it, and then you can relax the rest of the day.
And I used to do it in the evenings too, but then work got in the way, you were tired, things happen at home. So if you just do it first thing,
and
it's
long day. My wife wants to start cooking dinner, we're starting to prepare food, my kids are all grown up now, so it's just the wife and me together. So, I don't have that enthusiasm in the late day, so I try to get it first thing in the morning.
Same here. Very nice. So, can you share a little bit about your journey from New York to Cleveland here?
Well, I've been here about 19 months. I spent my past 30 years before coming to CASE, and the CASE Comprehensive Cancer Center. 10 years at Columbia University. I was, as you mentioned, I was head of Hematology Oncology. I was also deputy director of the cancer center there, the Herbert Irving Comprehensive Cancer Center. And I built a program there from a small program to really a major cancer research clinical program in northern Manhattan, which has its own issue of underserved patients and a more Hispanic population north of Manhattan. And then before that, I was at Memorial Sloan Kettering for over 2 decades, 20 plus years. And there I was head of the melanoma sarcoma program. And I was involved in some of the very first discoveries in advancing melanoma, new discoveries in targeted therapies, immunotherapy, which has become almost standard of care today for many of our cancers, and drugs that turn on the immune system to kill cancer. And we have great successes in that. We've taken melanoma from an incurable cancer. When I first started, if you live 6 months, that was considered a success story. Now we have well over half the people living 5 or more years, even with very advanced disease.
Nice, nice.
I think Jimmy Carter, our former president, is the best example of that. Here's a man who had not just melanoma, melanoma to his brain. Without, if you lived 4 weeks, 6 weeks, you were considered that was the best you could do. This man's alive like 7 years.
Wow.
At the cure.
Wow.
So that's what we can do with cancer medicine today in the right circumstances. Now, not everybody responds the same way to these drug therapies, and that's part of the understanding who benefits, who doesn't benefit. I take care of patients where they don't respond quite as well, but overall, we've made great advances in cancer medicine today. We have long ways to go. I think, we're very good at cancer therapeutics. We need to get somewhat better at how to prevent cancer. And I think that's where diet, health, and nutrition comes in.
Absolutely.
How to really build on that to make sure we provide access to all the right foods to people to, we don't understand exactly how health and food contributes to prevention, but I do think it contributes to preventing cancer, clearly preventing many other health-related illnesses that we are dealing with, and how to avoid those bad foods and how to improve your physical activity and get those good foods you may need to prevent cancer or improve other medical-related diseases is an important thing. We need to make people aware, and really clearly we need more research.
Yeah, we do need
to better
more
understand
research.
it as well.
Yeah. How do you define bad food? What do you consider bad food?
Well, I think anything that's processed food is a problem. And I think our kids eat a lot of processed food. I think, we have hamburgers and golden arches everywhere. And when I was in Columbia, I used to show a slide called the Golden Arch Syndrome. Every block we had either Golden Arch, McDonald's, not offending McDonald's, but they're the Golden Arches. And we have a Wendy's, Burger King, Kentucky Fried Chicken, all fat fried foods and not healthy. And when I look around those same blocks, they go, where are the parks? Where are the gardens? In northern Manhattan, they don't exist.
Yeah.
You go, where can a kid after school play a game of basketball? Where can they go walk in a park? Now, Cleveland, to its credit, has made a major effort to build parks.
Yeah.
The Metro Park here is extraordinary.
It is extraordinary.
If you can find one, they're exceptional. But you go to a place like East Cleveland, there's no park. Right. There are lots of empty, buildings that are vacant, and lots that are abandoned. People need to have places they can exercise, get outdoors, and find a safe place to walk around. So we have pockets in Cleveland that clearly are accessible to many people to take advantage of the outdoor experience. Bike trails, going up north in the metro parks and along the Erie Canal and all those beautiful areas. I've been up there and biked them. They're beautiful. They're not easy to get to.
Right.
And you can start actually down near the football stadium area and bike up. So there is accessibility, but that's quite a ways up. So, I think that we certainly have access to certain pockets of our population to do healthy related foods and exercise, but not everybody has that same privilege.
Yeah, there's actually an effort, because kind of what we're trying to do in East Cleveland with this center we're trying to build, but behind that center, I know that the Metro Parks is actually trying to purchase that, so they can kind of create, there's green space there, but there's there's not a great place to play, or playgrounds, or bike paths, or anything you typically associate with the Metro Parks right now, So
I think wellness has to be a balance between proper food, access to right food, selection of the right food, exercise is part of it. Outdoor space is critical, and I think in Cleveland we've clearly made progress to much of the population, but we still have a long way to go to make sure everybody has that type of access, and there shouldn't be health disparities that exist relative just to green space. Right.
Agreed. So how do you define patient-centric care? What's your...
Well, I think patients have the needs of optimizing care, and I think everything, patient always has come. I always tell my residents, my fellows, that patients always come first. And it requires an empathy between physicians and patients that you can teach to some degree. Or you can learn as a young adult or child. I can always look at a rising medical student and future doctor by how they interact with the patient, and I can see whether they'll understand that empathy and that ability to relate to patients. And often it's really, you look back at the parents, what the parents taught their kids about how to be good citizens, how to be good people, and that gets translated up to being a good doctor.
Yeah.
So everything has to revolve around the patient. You have to always do what's best for the patient. You have to talk to the patient, listen to the patient, understand their needs, both medically and emotionally. And it's not just the patient, it's often the family. I deal with a lot of young adults, of young kids. You have a family situation. So it's really, our goal should be optimizing patient care, and that just from the very basics of care to the more advanced access to the latest advances in cancer medicine. But ultimately, you have to think what's best for the patient.
Yeah.
And it's challenging to make sure that balance is kept in place, that you bring successes, you hope for the best sometimes in difficult to treat cancers, but you have to be aware, that there may be side effects and toxicities, and balance those out about what's optimized for patient care. So patient-centered care is, my feeling is, we're here to be doctors in Cleveland, but you have to think what's important for the patient, how to optimize the best care possible. And we do have great care in Cleveland. Okay, we have amazing medical care.
Yeah.
We have two great hospitals, Cleveland Clinic, University Hospital. In fact, if you have to get sick anywhere, Cleveland might be the best place to get it. I mean, where else do you have that type of density of doctors and hospitals? Maybe Mayo Clinic in Rochester, that's way up in Minnesota. But Cleveland's pretty unique, and on top of that, we have an amazing university, Case Western Reserve University, that brings together all the research and the science of the great opportunities to maximize the care for patients, to make sure the patient is the center of everything we think about and do, because that's all that matters.
So you have kind of a unique relationship, because you're here at Case, you work with university hospitals, and you work with the Cleveland Clinic. I mean, a couple of decades ago in Cleveland, that would have been unheard of. So that's a very unique thing that you're doing.
The first medical oncologist who can actually see patients at both hospitals. I spent a half a day at University Hospital seeing patients there with sarcoma. It's a very rare cancer, it's a cancer of connective tissue, soft tissue. We see it in young adults and children as well. And I spent a half a day at Cleveland Clinic as well. I participate in the tumor boards, so I get to interact with all the faculty, the surgeons, medical oncologists, radiation therapists, pathologists, and all those disciplines. And we meet twice a week on every single patient seen, either UH or Cleveland Clinic, so I can contribute to the patient care wherever they may sit. And to me, it's a great experience. So it's also providing me the opportunity to really learn the faculty, who's who, give me perspective that my predecessors did. This is not the model they had. They either aligned with UH or Cleveland Clinic.
Right.
So I'm not aligned with anybody. I'm a UH guy. No, I'm a cancer center guy from Case. And I'm a UH person and a Cleveland Clinic person, and that's and it's a beautiful thing, and I'm completely unbiased. And my goal is to really build the best cancer medicine for all Cleveland. And whether you're talking about patient-centric, whether you're in Cleveland Clinic or University Hospital, you get the optimal care from the best doctors, taking advantage of the best research that exists anywhere in the country. And we have great research programs, and we have great doctors. And I've been very impressed.
Nice.
And that's actually after spending 30 years in New York. We had 5 cancer centers, right? And here we have 1 comprehensive cancer center and 2 clinical cancer centers. And it's really extraordinary.
Nice. It's very unique. And I'm glad to see you're doing it. I mean,
I'm glad to be here.
Yeah.
This is sort of I've been through a lot of changes in my career, mostly in New York. But, this is something I thought would be an extraordinary opportunity to do something really different, to really take advantage of all my experience in both clinical research and cancer care and cancer medicine and even basic science, and bring it all together in one place. I was lucky to have my predecessor, Stan Gerson, who was the former cancer center director, now the dean of the School of Medicine. Here, he built the foundation. I'm standing on kind of his shoulders. Where do we go from here? How do we build further? But it's unusual to have a dean of the School of Medicine being a cancer guy and a cancer center director doing, of course, cancer. So it brings us together in a specific way that's pretty special. So he understands cancer medicine, the importance of it as a dean, and I understand how to build upon that. So we have a unique relationship, and I think it's going to help everybody. It's going to help Cleveland. It's going to help our community. It's going to help us build programs going forward.
So how do you see influence? Because you made an interview you did, you talked about 4 million people in 15 counties.
Right.
And so how can they influence a reduction in cancer, I guess? I mean, I know working together is important.
Well, I think working together is critical. I think, having access. We have 4 million people. The Cancer Center represents 15 counties, 4 million people. Between UH and Cleveland Clinic, we see 80% of all cancer patients. So that's, the vast majority of people who get cancer are seen at one of our affiliated hospitals. So the beauty of the program is we can push out the research to 80% of patients with cancer. And although those patients who aren't in the cancer can still find us and participate, we want to be inclusive. So this ability to link everybody together through the CASE Comprehensive Cancer Center allows us to establish clinical research programs, which are innovative new approaches in cancer medicine to anybody wherever they may exist in all 15 counties, and hopefully provide the optimal care possible. And also we talk about not just therapeutics, but prevention too. We do screening programs. We're out there looking for early stage colon cancer. We know that we're seeing younger people get colorectal cancer. We're really not sure why. Is it dietary? Is it environmental? We don't know. But we're now seeing earlier people get certain cancers, which we never saw before.
Right, right.
Colorectal cancer was a disease of people in their 60s and 70s. Now we're seeing people in their 30s and 40s getting colorectal cancer. It's kind of scary.
Yeah.
And we're not really sure why. Esophagus cancer, also earlier people. How do you prevent that? How do you detect it early? So we're putting programs in place in the community for early detection and prevention. We even developed a special for esophagus cancer, for example. We developed a special little balloon that goes on a plastic tip. You swallow it like a little pill. You put it down to the esophagus and the stomach. It captures cancer cells. You pull it up, and we've detected a number of DNA genes that if they're picked up in the cells, is like 99% chance you're either going to have or get esophagus cancer.
Wow.
And this has now been developed at CASE with our group in GI Oncology. Sandy Markowitz and his team is a FDA-approved product. So now we're pushing that out to the community to really lead the effort in early stage esophagus cancer detection. Colon cancer is to follow. We're looking at similar technology as well. And there are some now blood tests that have just been approved to actually pick up early stage colon cancer before it fully develops. So we're about to engage in not just the therapeutic part, but the prevention part. And Franklin said an ounce of prevention is worth a pound of cure. And I really think that's true. He was referring to fire departments, by the way. It wasn't medicine, okay? Because in those, he formed the
Everybody always takes that as referring to medicine.
He was actually formed the first fire department in Philadelphia, and that was in reference to the first how to prevent fires in the home. But we can apply that to anything today, and I think we have to take that. He was right. So we need to not just think about how to treat the disease once you have it, but it's a lot easier to treat the disease before you get it. And that's where prevention strategies come in for screening. Cervical cancer, for example, is a very preventable disease with a diagnosis with a pap smear. There are now vaccines to prevent cervical cancer. How to get those vaccines out to the community. That's 100% preventable, cervical cancer. No one should get it. There's a vaccine. Now, of course, the problem is you need to vaccinate young adults and children. Right. And there's a pushback to give vaccinations now to kids, right?
Yes.
Even though it may be highly preventable, or people don't believe their children engage in sexual activity. There are communities here, pockets that don't think that's possible. Well, kids have sex, I'm sorry. Okay?
My wife's a teacher, so yeah.
Parents may not believe it, but they do. We're not going to get down that road here on this podcast, but for God's sakes, okay? Okay? But there is a vaccine to prevent cervical cancer for women, and actually head and neck cancer. Because the virus, the herpes virus, children have oral sex, and it causes cancer. Michael Douglas, good example. He had head and neck cancer, but curable. But you don't want to have to go through the therapy, for goodness sakes. It's really rigorous. It's combination chemotherapy, radiation. It's very toxic. It's treatable and curable. But we have a vaccine to prevent it. So how do we get through some of those social barriers to have those discussions on some touchy areas? And it doesn't matter where it's those same discussions are, whether you're New York or Ohio. There are the same barriers that exist to having discussions with families, but we have preventable cancer. So how do you get that information out there? How do you have those discussions?
Well, and how do you get the screenings done so regardless of what path they want to take, at least identify that. Now,
UH has a program where they actually reward the physician with a remuneration, monetary, to get a kid vaccinated for HPV, which is the cervical herpes virus, how to increase those vaccinations. So there's a motive of now a financial push to try to encourage doctors to get those kids, the pediatricians, to talk to their family members, their parents, and with or without the child present, the importance of getting vaccinated for at least HPV-related illnesses. We could cure cancer altogether with some cancers with the vaccines. And I think that's going to become more, we're going to use more and more vaccines going forward. I know there's going to be a big debate, I think, in the next 4 years about where vaccines should sit. And that's not the purpose of your podcast today. But I think you have to listen to the science. I think there are, there was this link between vaccinations and autism. One paper, completely debunked. That data is completely, it's not that it was just completely misanalyzed. I'm sure it was good intention, but they've gone back and looked at that data. It's completely negative. There's no association, zero. But it got embedded in the literature, and people believed it, grabbed onto it. They felt it was autism. How can my child be autistic? It must be something I did to them, or that medicine did to them.
Right.
Let's not blame, we don't know. We don't know what causes autism. I wish we did, but let's blame something, right? So one paper comes out, links it, that's history, right? That's not how we should approach a problem, right? We have to think about the bigger implications of what all that means. So we'll see what happens the next 4 years. We have certain anti-vaxxers who've moved into the White House, and it could impact everything. A lot of things we're doing today, and the vaccine trials and access to vaccines for kids and for young adults could be impacted by what happens. I hope not. I hope people listen to reason.
I hope they do. Listen to reason, listen to science.
Listen to science. Science has to be what guides us. And I'm here to only speak the truth in Cleveland. Okay, that's what I'm here. I only speak what's true. I'll never make a proclamation as Cancer Center Director to do anything but to benefit the people of Cleveland and Northeast Ohio. I'm here to help.
Nice.
Okay, I'm not here going to lead people down a path that's not going to get them to improvement in health and medical care.
So how about you're doing some work in East Palestine, Ohio? So that's where the train derailment happened.
So it's interesting. So that derailment, I started April 2020. I think the derailment happened in February. I'd already accepted the job January 1st, and I didn't start until April 1st. So I called up the people at Case, Fred Schumacher, who was a member of our Pop Sci program, and Erica Trappel, who is now our Director of Community Outreach and Engagement, said, what are we doing? This huge derailment, it's 90 miles or so away from the cancer center. These people need help. Should we be talking to them? Well, we didn't want to seem obtrusive. We didn't want to start, brandishing the big C word, right? Okay, until we knew there was a cancer risk. But you got polyvinyl chloride in the air, for God's sakes. Let's be honest. There's got to be some cancer risk. And it's in the soil. And then I was reading about how they imploded to try to whatever their goals were, and now it was in the air. They're cleaning all this ground, and groundwater is being contaminated. So we actually were contacted by the community. They reached out to us. They said, EPA is leaving. They'll here a short amount of time. We're concerned. We're concerned about it for our children, concerned for ourselves. What is the cancer risk, and how can we be monitored and followed? So Fred and Erica went down to the community, met with them multiple times, and they said, we'll do whatever it takes. So we have a clinical trial that's actually supported by the NCI, NIH, to support our efforts. We got this grant in right off the bat. Initially, we gave support through the Cancer Center before the NIH came in and gave federal support. We actually used Cancer Center dollars to go down to the community and begin to monitor people over time. We took histories, background, current, and we actually, they're submitting blood tests periodically to see, can we pick up chemicals in the blood? Can we pick up genomic gene alterations, damage to their DNA, which may take place over time. And we're going through all this, and we don't have any data yet, we're collecting all the blood. It's you have to, and we don't do it without, we do it only if you volunteer, okay? So what we did, we went to the fairs in the summer, the county fairs. We set up a booth, health and wellness, happy days. And we have a booth, and we have someone sitting there, and people walking through, looking at the prize pies and pigs and horses, and there's a Cancer Center booth right there in the county fair. People walk up and they want to know about it, and we explain what we're trying to do. They say, well, we're from the community. We'd love to participate. They sign an informed consent. They fill out a form about history, and we follow them. And you don't have to give a blood test. We encourage it. It's not required for the protocol. But actually the number we've had hundreds of people participate.
Nice.
And over 90% have agreed to give a blood sample as well as part of this because they're scared.
Yeah, you should be scared. I mean, based on what happened.
It's scary stuff,
yeah,
right?
It is scary stuff.
So that's our East Palestine presence. And this started before I even became the director. I just recognized the problem. The grant was due April, like the second week I came. I started like the second week of April. So we quickly put the grant together and submitted it. And we were successful in the application. We actually talked to the other cancer centers. We got University of Pittsburgh involved because the toxic plume wasn't just in Cleveland, or just wasn't in our catchment area in East Palestine. That toxic plume went up to Pittsburgh, right? And we got Columbus involved. I knew the cancer center director there, and then some of the, depending on how the wind was blowing, right?
Yeah.
So this really was a large-scale effort to engage multiple participants, and really I think it's a huge impact. And we'll see what it shows. It's complicated. How do you pick up damage to your own DNA, and how do you look for that? And that's something we're not sure exactly how best to approach it, but we're going to try the best we can. And I want to reassure the people of East Palestine that we're there for the long run. We're not coming and going. I'm committed to making sure we see this through.
Nice.
And we'll see. And hopefully there'll be no cancer risk.
Right.
But if there is, we'll be the first to pick it up.
Okay.
And help provide them the necessary guidance they need to live a normal life.
Very nice. Another thing you're working on is with barbershops in black communities.
Right.
You're talking about prostate cancer. How did that come about? How's that going?
Well, we're very committed to engaging our community members. It's one of the main, I think cancer centers have evolved. It used to be white ivory tower, science. No one ever saw the community. You did the basic science, you did your work, you closed your door. Our goal is to really make sure our science reflects the needs of our community. We have a big underserved community in Cleveland, whether it's parts of the city itself. I mentioned East Cleveland. People don't have access to drugs.
Right.
They don't have access to great medical care. First, everybody should have access. There should not be a difference between your color of your skin, your racial or ethnic background, and getting the latest advance in cancer medicine. Everybody should have access. Without that, there's going to be huge health disparities, and that to me is unacceptable.
Yeah, agreed.
So we have to address that. So, how to make sure, so the goal of our cancer centers today is to make sure the cancer research we do reflects the needs of the community. So how does that relate to prostate cancer? So it turns out prostate cancer is increasing among African American men. They get it earlier, and they get it at a younger age. And when they get it, it's more advanced. Now, is it just late diagnosis? Is it biology? Something driving it differently among African American men than Caucasian men? We don't know. It's an area of ongoing research. But the first thing we need to do is find ways to detect it. Now, how do you engage a member of the community that doesn't like seeing doctors, doesn't want to be, doesn't have access? So what might be better than the barbershop? So, it's a social center. So we taught the barbers of Cleveland how to have a conversation with their clients Saturday morning when they're getting their haircut, or whatever day of the week it is, and how come prostate cancer is an issue. And there's a test that we can run in the blood called the PSA, prostate-specific antigen, and we can tell you if you're at risk for prostate cancer. It's not guaranteed.
Right.
At least we can detect it and screen for it, and then refer to the best possible care you need to make sure you're taken care of. And then once we talk, and not only we educate them and how to have the conversation, but in every barbershop we have a running video screen of patients, African American men, who've had prostate cancer, talking about their experience. They were sitting there reading a newspaper, whatever, or magazine. There's running screen going, and then we have African American physicians talking about being doctors who are taking care of patients with prostate cancer. So, we know that people of color like to see doctors of color. They relate better. We need to increase that doctor of color. We need to increase diversity in our population, because we know that allows for a better conversation, more agreeable to participate in clinical research, but even get common medical care. So that runs at the same time, and we've been hugely successful. I don't know the exact numbers. We've done hundreds of screens.
Nice.
But the most amazing thing is we've already picked up early prostate cancer. We've picked up 1 or 2 men with early stage prostate cancer, and we put them into the system, and they're cured.
Nice.
So I can say our system has already cured cancer. And it's a lot easier to cure it by preventing it,
right,
than to treat it when it's an advanced disease, because then it's not curable.
right.
Then it's medicines and toxicities with that. So that's the Barbershop program, and it's hugely successful.
Nice.
And
nice.
we're happy about it. We've actually been approached now by other cancer centers to make it a national program, and even make it maybe even a federal level program. This is no one's ever done this before. Once we're so successful with this, the next thing, should we do hair salons for women? Now talk about mammography, because women, African American women, similarly get a unique type of breast cancer called triple negative breast cancer, and it's hugely aggressive, and it's also younger people, and we don't know why. So more research being done. We have a big program on how to treat it. We're developing new therapies here through our basic science programs, now into clinical trials. But again, early detection. The earlier you pick up a lesion, the more curable it is. You want to pick it up before it's almost detectable on a scan.
Yeah.
How to pick it up in early stage MRIs or mammography. And that's what we want to bring next into the community.
Nice. Is that a blood test too, or do you have to do?
No, that's an imaging study. So mammography is, there's no blood test yet for early stage breast cancer. That may come eventually.
Yeah.
But this is an imaging, radiology, and how to make sure how to get those imaging machines to the community.
Right, right.
So that's a different challenge. It's a lot easier to go in the community with a van and say, roll up the window, can we take a tube of blood?
Right, right.
But you have to have a whole machine and get them to the right area. But we're offering, for example, the Langston Hughes House, which is a community center on the 62nd Street.
Okay, okay.
There is a mammography unit there. Anybody can walk in and get free mammography, even underinsured. Cleveland Clinic's running this program. I saw it last week for the first time. It's awesome. The same thing for the prostate cancer program. If you get prostate cancer and we pick it up and you're underinsured, we're going to treat you to the very end. We're not asking for a penny. University Hospital agreed to full commitment. Anybody picked up, they'll pay for the whole ride.
Wow.
Okay? Because there are people insured or not highly insured or even underinsured.
Yeah, yeah.
We will take care of them through the whole process.
Nice. That's very nice.
So we're committed to bring the best care to everybody in Cleveland and our counties, no matter what your socioeconomic status is.
Well, I definitely want to get that message out.
Yeah.
I did not know
Yeah.
that.
So, so that's just two examples of no matter who you are, whatever your income status is, we want you to understand we are here in Cleveland as a cancer center with these two hospitals to help you. And if that's one thing I can get through, and we're here to make sure it happens and you have access and there's way into the system, and you shouldn't be afraid. Cancer is scary, right?
Yeah,
it is scary.
It is scary.
You get the word big C and cancer, but there's so much more we can do today than we can do even 5 years ago. Early stage detection is critical. Okay, I can't emphasize that more. And the treatments are hugely advanced without the toxicities and the side effects we experienced 20 years ago. So I've seen huge advances in this field. And everybody should have access to what we have going on here.
Nice. So cancer is the second leading cause of death in the U.S. So the
Right.
figure I pulled is like 600,000 people annually. That's a lot of people. And you've written dozens of research papers over your career focused on different cancers. So I guess I'm just curious. So you've done like research on bladder cancer, colorectal, breast, esophageal, thyroid, pancreatic, and more widely on sarcoma and melanoma cancers. Right. So why did you focus on those specific areas over the last?
Well, I was first a GI oncologist, and then for reasons that are historical, I eventually merged into rare cancers such as sarcomas and rare forms of melanoma. Melanoma, when I first started, actually, there were no therapies. It was a horrible disease. And then I got involved in something called uveal ocular melanoma, which is, there's a melanoma of the eye, believe it or not, terrible disease, young people get it. And then sarcomas, which are cancers of soft tissues. And I became to aware that what was one of the frustrating things to me is that when you look at these rare cancers, there's very little research that goes on, very little support from the pharma doesn't care. Pharma, in fact, unless you have breast, colon, lung, and prostate, which are important diseases, don't get me wrong.
Right.
There's no pharma support, or very little pharma support. There's no market.
Right.
So they don't want to invest in that. Research dollars, at least when I first started, were very limited. But look at rare cancers. These are, when you go beyond those big four, everything's considered rare. And there are 2 million cases diagnosed of cancer a year in the United States, okay? 1 in 4 of them are by definition rare. That means there are 500,000 newly diagnosed rare cancers in the United States, and for most of those, there's no established therapies, There's no funded research. There's no pharma support for clinical trial development. So I decided I'll become an advocate for those people. Nice. And that's where really my focus has been. I'm actually chair a special committee that's for clinical trial development. If you have a company has a new drug, or say an academic center finds a new drug for a rare cancer, we have the ability now to establish a national network of clinical trials. We look at the data. We have a committee. If it's compelling and looks really great, we'll then work with the NCI, and we have a network in place with over 300 centers who can run a clinical trial. Because the rare diseases, you can't just do one center. You need everybody to participate. So no matter where you are, whether you're in Bangor, Maine, or somewhere in Southern California, or Omaha, or Ohio, there are centers for these clinical trials. So everybody can get in, and everybody can participate.
Well, that's still a lot of people. 500,000 people is not like
a lot of
like
people.
50 people, yeah.
And we need new ideas, right? Because many of these studies, these tumors, we don't even know what makes them grow.
Right.
So we have to do more science. So one of the things I'm bringing to Cleveland is a whole scientific program around rare cancers, and finding donors or philanthropy to help us build a rare cancer initiative in Cleveland around our two great hospitals, and trying to engage also all the other cancer centers across the country to address the issue of how to bring new treatments, new discoveries into the rare cancer community, and to rapidly move those discoveries from a laboratory discovery into a clinical trial based on whatever, a new target, a new pathway, a new drug. Let's move it quickly from the lab to the clinic and get these drugs out to these patients where there really are no established therapies, because many of them, there are no effective agents. So we have to really make an advance in this rare cancer community, and I think it's something that I feel very passionate about, and I'm hoping we can make Cleveland an epicenter for this. Something unique and special. 1-800-RARE-CANCERS, come to Cleveland. We're going to find a way to take care of you. So that's what I've been working on really a lot of my life now. That's the rare cancer background. That's how, if you look at a lot of those tumors, many of them are coming under the rare cancer definition.
So do you see all the research that you've been participating in, rare and other, do you see any commonalities? Like, is there one or two things that people can do or change, or lifestyle, or I mean? Well,
it's hard because I get asked a question all the time. Like, they get these rare cancers, like a sarcoma.
Yeah.
And you ask me, so Dr. Schwartz, what made this happen?
Yeah.
And we don't really know. We need to do much more research. I'd say it's either bad genes, genetics, but we often can't find a genetic hereditary pattern. Many of these happen spontaneously. If you look deeply, sometimes you can find a hereditary tree, but more often than not, there's no known risk factor that we can identify. Then you have to think it's environmental. And we don't know what environmental factors cause many of these cancers, which gets back to good health and living again, right? And what you can do to help yourself.
Yeah.
Now, we don't know whether healthy foods prevent all these cancers. I like to think it does, but you can help yourself no matter what by approaching healthy diet in a way to give you some edge. And people also ask me, going back to the food and nutrition, what food should I eat? And it's an area we need to do a lot more research on.
Yeah.
When I was in early days oncology, before we had these drugs that activate the immune system, we have all these new drugs that turn on the immune system to fight cancer. People used to bring usually a Bloomingdale. When I was in New York, Bloomingdale bag was everybody carried one, and it would be full of bottles. And they take the bottles and they pour them on the table and say, Dr. Schwartz, which of these are going to prevent cancer? Which of these are going to activate my immune system? And I go through the bottle, do my doctor thing, and I try to be, empathetic, but I knew in my heart that I didn't know, and most of them wouldn't do anything.
Yeah.
I went through the bottles, and I try to be the good doctor and spend time with them going through those, and it's a challenge to know what people can do from an herbal point of view, from a medicinal point of view. I say 99% of those medicines have no effect.
Yeah.
There's a lot of, folklore, social media stuff that goes on all the time.
Yes.
How to interpret that data. So there was even a social media this summer that putting suntan lotion on your skin, SPF 30 or greater, prevents skin cancer. Easy, right? Melanoma is a bad disease. We have therapies for it, but you can prevent it by using either loose-fitting clothing if you're at risk, or just reapplying sunscreens to prevent getting sunburn, because sunburn causes cancer. In fact, The most potent carcinogen known to man is the sun. Okay, it is stronger cause of cancer on the skin than smoking. Look at the number of mutations that are formed by sun. It's greater than smoking.
Wow.
In fact, because there's so many mutations in a melanoma, that's why it's so sensitive to immunotherapy. We've shown that the immunotherapy responsiveness is proportional to the number of mutations.
Wow.
And that's why melanoma is even more sensitive to immunotherapy than lung cancer. So this summer there was a social media thing that skin cancer prevention, those preventions will cause skin cancer, right? It was in social media, right? That not to put them on at all. There's something in that sunscreen that's going to cause skin cancer, okay? Some contaminant. Now, where that came from, I have no idea, but we're having trouble convincing adolescents and young adults to put sunscreens on this summer because the social media was putting this rumor out that sunscreens were contaminated with pro-carcinogens. Not true, okay? So this is what happens today, that these myths get generated, and then we as physicians have to find ways to fight them and bring truth back to the story. But going back to the story of the bottle, so this is what we face, and I think there's no panacea for prevention at the moment. I think we looked at things like aspirin for a while. Would aspirin prevent cancer? Though most of the studies are negative. Vitamin D is still debated. Or there's a role for vitamin D. A long time there's a big vitamin C issue, and I think that probably that doesn't really play a role. But a lot of these issues are still unresolved because we really haven't had great clinical trials. Because to do clinical studies, you need thousands of patients, right? And we don't really know how to do those in those large-scale populations. We don't do them very well. We know how to do them, but we don't do them very well.
Well, you got to do them over time too. It's not just like a 2-week study or something.
No, these are long, and you have to follow patients for long term.
Right.
Who's going to support that study? Pharma companies want answers like weeks to months, right? They don't want things that are going to take months to years to follow through on.
Right.
So who's going to support a study like that? That's the challenge.
Yeah.
So I think we have a lot to learn about healthy eating and about diet and prevention. But to me, that is something we need to really focus on. That's where we need our investments. Because ultimately, I say it again and again, preventing cancer is the best thing we ever could do. And I think we can understand healthy diet, bring that to the patients, and not the patients, the people, before they get cancer. It'd be huge.
Yeah, I mean, at least other people that I've talked to, you can kind of say, well, ultra-processed foods didn't exist 75 years ago. They exist today. And there's been an increase in cancer over the last 75 years. So there's an association there, but we do need the research to kind of
we need the research to prove it.
Yeah.
Fatty foods, leaner beef, cuts of beef, more fish in the diet. I think there are a lot of things that can be said about Mediterranean diet. More fish, more olive oil. Those things I think do help. At least I think they help, right? That's what I do. In my own mind, I've decided they help me. They make me think I'm helping myself.
Yeah.
Clearly not hurting, and I think that's the key part of it. Now, alcohol is another issue. We used to think that a glass of red wine a day would prevent cancer.
Right.
Now the data showing even one glass of wine may cause cancer. So this is like the confusing things.
Yeah.
Things we're advocating in medicine. An glass of red wine would help high blood pressure and cholesterol and cancer prevention because of the grapes would be antioxidants.
Right.
And here we are now, full circle with all the data coming out saying that alcohol of any quantity may be bad for you, right? So it's very confusing.
Yeah.
It's I'm a physician. I do science, but it's still confusing no matter where you sit and what do you recommend. I've always preached moderation. A patient comes up to me and said, "Can I have a piece of cake?" Because there's this bit about glucose causing cancers.
Right.
And we even have scans that are glucose driven. But, I think it's going to require high dose sugars to cause cancers. So I preach moderation. I say you shouldn't deny yourself things that you want them. A piece of chocolate cake, how bad can it be?
Yeah.
Okay?
As long as you're not having it every night. If you're having it as a celebration,
exactly.
Why not? Yeah.
You shouldn't deny yourself.
Yeah.
I mean, there are people who decide they're going to change everything in their life, like throw everything out the door, not have a ice cream cone or a piece of chocolate cake or whatever they want. I say, well, then you lose the pleasure of living, right?
Right. You gotta, yeah.
You have to first find that right median for yourself, what you feel comfortable with. But, until we know for sure how these things impacts life and survival and cancer risk, I think we can't overinterpret some of them or misinterpret them.
Yeah.
So I've always believed in the moderation approach. But there are things that even now, moderate alcohol may be wrong. One glass of, I don't know, and what do we do with that data? So I'm still waiting for more data about that. But that's part of the challenge. What we think is things changing so quickly, and it's confusing to the public.
It is confusing because there's a lot, like you say, on social media out there, limited research, and just people are drawing conclusions. Right. Yeah. I mean, the blue zones, there have been studies in the blue zones, and that seems to be some data there that kind of supports kind of, we're talking about exercise, a little bit, focus on
healthier living.
Yeah.
But I think we have to, there are parts of Cleveland we have to figure how to provide better access. I think East Cleveland's a good example. I mean, it's not Cleveland City, it's outside Cleveland, but it's within a mile and a half to 2 miles of this office. We're in East Cleveland, right? I get in my car, you go down Euclid, and you're in East Cleveland. It's not like it's a different part of the state. It's a neighbor, okay? And where's the nearest food store? Where's Dave's?
Yeah,
there's no Dave's.
There is no Dave's. Yeah, 2 miles to Dave's. Yeah. 2 miles to Myers.
And there's no public transportation. See, New York, where I spend a lot of my life, you can get on a subway or a bus, and the subway would take you to anywhere. There's no subway system here, so you need public transportation. It's not that great for that part of the city.
Right.
And people don't always have cars. They don't want to drive. So, what do you do? They have these gas station shops, that are probably more predominant. They're for vapes and for cigarette products, mentholated cigarettes, which are a scourge to our community. Menthol cigarettes, an addictive factor. 80% of African Americans smoke a mentholated cigarette, only 20% of whites, because menthol is an addictive factor like nicotine. And we have marketing targeting the African American population in Cleveland, contributing to the addiction in this community. We have the highest smoking rate in anywhere in the country, and we have the worst outcomes. More people die of lung cancer in our Cleveland area than anywhere else in the country.
I did not
from
know
lung
that.
cancer.
Okay.
The mortality is the highest in the country. Okay, because people get diagnosed late and will come in with more advanced disease.
So it's back to the early detection.
And it's prevention.
Yeah.
Let's change policy.
Well, that too, yeah.
Right. Let's get menthol out of the cigarettes. We can't get it done in Cleveland. Can't get it done in Ohio. That's up to the community. So Columbus, for example, they have a ban on menthol. Okay. It's now by community. We can't get the business community in Cleveland to agree to a ban on menthol.
Wow.
The small business people say, well, if they ban it, we're going to lose my clientele, and they're going to go outside the city and find it someplace else. Well, they've studied this, and if the business communities listen to this podcast, there is a drop in income initially, but eventually people come back. Okay, they love those little stores.
Right.
Okay,
right.
They find other things to buy. Okay, but they don't come back to buy mentholated cigarettes because that's contributing to a critical effect on our community, and we owe it to our friends, our neighbors, to protect them. And I think the business community in Cleveland has to understand there's a bigger obligation, and they will make it back financially. That's what everything shows. But we cannot get a policy in place in this city to take menthol out of cigarettes. And we could. It's now been the state of Ohio, the Supreme Court has ruled that the state itself cannot control this issue. That was a big issue with the governor. He was trying to bring it to the local community. The state legislator said, no, we're going to control it. Of course, they didn't want it because there's a big tobacco lobby in Columbus. Gave it back to communities. Communities control this. We can control our fate. And smoking is a horrendous problem.
I had no idea it was that big of a problem in Cleveland.
Yeah, we have tried. We have a big smoking initiative to engage the community on smoking. We have big programs with smoking cessation programs that we support. Okay, Erica Trappel here is a big advocate for that. We actually do smoking cessation for the community. Okay, but we cannot get the city of Cleveland to ban menthol. Okay, we're not banning smoking.
Right.
Okay,
Right.
We just want to take menthol out.
Right.
But it's such an addictive factor for a big segment of our population.
But I guess it's also back to the education thing again, right? I mean, you want prevention, but also education. I didn't know that that was a big problem in Cleveland. I don't know how
It's
many
those
people.
cool cigarettes.
Yeah.
Look at the cool ads. Those aren't white people on those posters. Those are African American men and women smoking those cool cigarettes.
Yeah.
Right? It's cool, right?
Yeah.
It's not cool. Okay, this is not cool. This is bad.
Yeah.
But that's what we have to do at the Cancer Center.
Yeah.
We need to get this information out.
Yeah, exactly.
And hopefully we can
Education,
evoke a change in public policy. I'm working with the city trying to figure this out. But this is a challenge. As long as there's a concern for financial impact, we're going to be challenged. But I can say emphatically that it's short term.
Yeah.
You'll make it back.
They'll make it
They'll
back.
make it back.
Yeah.
But these are easy things to fix.
Those are. It is an easy thing to fix. I agree with you.
It's a lot easier to fix this than to treat a patient with advanced lung cancer who's going to die of their disease. Yeah, we have immunotherapies, we have new treatments, but for goodness sakes, let's do the easy stuff and do it together and set an example for the whole country, right here in Cleveland.
So another thing that affects cancer in a bad way is obesity that you've talked about as well. So what can we be doing on that side? So we're talking about smoking, but obesity, how can we?
Well, obesity is, definitely 3/4 of Americans last week were called obese, and it's more African American than white. Okay, so I think part of it is access to good, healthy food.
Yeah.
When you're sitting in East Cleveland or in a community and there's the Golden Arch Syndrome we talked about, and you got all the Wendy's, the Burger Kings, and no parks.
Yeah.
And you can't find a store to buy a head of lettuce or a head of broccoli, which I think is those important foods. Especially, I think there's certain things that have antioxidants, like broccoli is a good source of antioxidants. But you can't if you're coming home late at night and you had a long day, and you say, I got to run to the store, right, to pick up a head of broccoli or get some blueberries for breakfast, which I advocate for. Where do you go, right? I guarantee you that smoke shop down the corner at the gas station is not going to have that, okay?
I've been in some of them, they do not.
Right? They don't, right?
No, they don't.
So where do you go? So you don't eat that.
Yeah.
Or the mom and dad is too tired, they've had a long day at work, nothing's on the table. So go to McDonald's.
Right.
Right? Bring home a Big Mac, right? And it's not just once in a while. Again, everything in moderation. I'm not saying you shouldn't eat Big Macs,
Right,
okay?
right.
But when they come your diet with the French fries
Right.
and the big shake, that milkshake, which has no milk product at all, okay? But all sugar.
Right.
Okay, this is bad. And you do it repeatedly, that's bad. So what do? You got to how do you provide access? How do you make sure people have access to healthy food? So we are developing, at least for parts of our community, through the Cancer Center and through both hospitals, access to healthy food. We're putting food pantries in multiple sites where people can actually get healthy food free. These aren't handouts. It's free, but it's not like a food bank where they hand you stuff.
Right.
You go to these new food pantries, and we're developing a whole bunch of them. You take a cart, it's like a store, you take what you want, and you take what you need. And it's really, I think, going to make a big impact. In fact, if you're a patient at a university hospital, and you tell your doctor, I have no access to good food, they can write you a prescription. And you could take this to one of these food pantries and get it all for free. And take as much as you want.
Nice.
This is amazing.
It is, yeah.
This is an amazing way of trying to connect people in Cleveland to these food pantries to provide them access to the food they need.
Because you're also doing it. I actually interviewed Selena Kunan.
Right.
She brought in a patient. This was probably 9 months ago. But that patient had access to one of those food pantries.
Right.
And she was able to go from being on 26 different medications to less than 10 because she had access to that food pantry. I mean, that's huge.
Look, we've got to get salt out of the diet.
Yeah.
Salt definitely is a contributor to hypertension and high sugar, diabetes. And God knows which of these things are going to contribute to cancer. But there's a clear association between obesity and cancer.
Yeah.
Okay? It's been shown. That link is so strong now. Okay?
So, as I'm doing the editing, I realized that when Dr. Schwartz and I were talking, I received a phone call that interrupted our conversation. So what I'm going to do is read, to close out our conversation here, the recipe that he provided when we were talking. So I asked him if he had a recipe. He said, of course I have a favorite recipe. He said he was challenged at first, but he knew that his favorite recipe was his roast salmon recipe. So you heat the oven to 400 degrees, mix in 2 tablespoons of brown sugar and 2 tablespoons of Dijon mustard. You take the 4 6-ounce salmon fillets, add a little salt, a little pepper, just enough to give it some flavor. Place the skin side down on an oil pan, the salmon fillets, and then put the sauce on top. to coat and cover the top of the salmon fillets and put it in an oven for 12 to 15 minutes until they're done. It's very simple, and while the fish is cooking, you can cook a little rice either in the microwave or on the stove. Same with the broccoli, on the microwave or the stove, and you've got a very complete meal. So thank you very much for joining today. Again, our sponsor for the podcast is Cleveland Kitchen. They focus on gut health through their fermented foods, 2 forkfuls a day. Good for your gut, good for your brain. My opinion, good for cancer prevention as well. So thank you very much for joining us today. Have a great day.